wanted to just take a couple of minutes before I introduce our speaker tonight, and really just thank all of you. I want to especially thank Denise Cook for stepping up in her role as the chair of the National Leadership Council this year, taking over for Kevin Coffey. And I know many of you have met or know our Chief Scientific Officer, Andrew Heaton, who is also joining us by phone and might be available to answer any questions when we get to a Q&A with Dr. Hoffman. Let me just say that as a sort of setting a bit of this conversation up, that in my mind, and I'm about to enter my 6th year as executive director of Cure JM, I really think we have settled in on two really primary objectives for this organization. The first being better drugs. We know a cure is somewhere off in the distance, but better drugs are not. They are something that are ever closer within within our grasp, and Dr. Hoffman, as you'll hear, and Dr. Heaton are both at the forefront of what we're trying to do. Dr. Hoffman with vamorolone, and Dr. Heaton with several other drugs that you've heard me talk about in the past, a class of drugs known as JAK inhibitors. And then I think many of you also know that drugs like rituximab are becoming more of a standard of care for JM. We're hopeful that a clinical trial for another drug known as abatacept will be wrapping up here in the next maybe 6 or 8 months, and that a paper will be issued on that. There's a trial with 10 young JM patients taking place right now in abatacept, and that paper will, in a sense, pave the way, if you will, for additional use of abatacept. And then, of course, for many years, and we continue to do this, we fund a lot of basic research with the hope that what we learn in that research will ultimately support clinical trials and provide us with the platform that we need to prove that the drugs that we test in clinical trials are actually working. The second major priority that we have is improved care, really improved care from diagnosis to remission. If you really go back 15 or 20 years, 25 years to when far less was known about JM than is known today, it's probably fair to say that generally speaking, with a few exceptions like Dr. Pachman and Dr. Ryder at NIH and at Lurie Children's in Chicago, that the knowledge of JM and therefore the quality of care was somewhat lacking. We don't have that today nearly to the level that existed even 10 years ago. We now have 4 centers of excellence with the addition of Seattle and Duke. We have a number of additional institutions who I think are on the road to becoming centers of excellence. But in reality, we have entire areas of the country where there is somewhat limited, if not significant, lack of access to JM care. And this is something that your board of directors is very concerned about. And something that we're looking at how we can effectively address that by providing more support, especially to children's hospitals that have a reasonable level of JM care, but who could possibly up their game with just a little bit of support from the Cure JM Foundation. There are a lot of JM experts now, many more than there were 10 or 15 years ago. But there are limitations to what some of those hospitals and what some of those experts can do with that when they don't have the money to do it, when they don't have the money to buy the equipment they need or have the assistance they need, or even start small research programs. So So this is, this is why we're here as CureJM as an organization, to focus on those two primary aspects of our mission. I think we're making great progress. We've got some really fantastic information to start sharing with you today from Eric, and hope you'll ask really astute questions. I know you will in the Q&A session. So without further ado, I'm just going to move forward and introduce Dr. Eric Hoffman, our speaker for tonight. Dr. Hoffman is the co-founder, treasurer, secretary, and vice president of research of Reveragen Pharmaceuticals. Dr. Hoffman was the driving force in the development and the pending commercialization, if you will, of a drug you've heard me talk about in the past called vamorolone. I think of vamorolone as sort of the anti-steroid steroid. It is for us what is a hoped for replacement for prednisone, not just for juvenile myositis, but for other autoimmune and conditions where prednisone is an important part of the treatment regimen, but I don't need to tell you the side effects and other complications that come with its use. So vamorolone is in the process of wrapping up what I think is a phase 2/3, if I have that right, Eric, clinical trial in a drug known as in a disease, Duchenne muscular dystrophy, which has some similarities to juvenile myositis. And we're just very enthusiastic about not only the success that this drug will have in that particular disease, but the potential it could have for JM as we put together a clinical trial, which we hope to launch in its early phases in 2021. With that, I'll turn it over to Dr. Hoffman. Thank you for being with us, Eric.
It's a pleasure to be here. Thanks for attending. So I'll give a short presentation on sort of status of vamorolone. We've been working with CureJM for, geez, how long has it been now, Jim? 3 or 4 years.
That's correct, yeah.
Cosmos Club in Washington, D.C. And since that time, it seemed that vamorolone had some potential for replacing corticosteroids in juvenile myositis. And so I'll briefly go over the status. We've had a lot happen over the last 6 months, and then sort of where we stand. I should mention that we already got a $250,000 grant together with you guys from National Institutes of Health to do biomarker studies that probably Jim's talked about, and that was published then. So with biomarkers, what's key there is that you can have sort of acute readout. So within a week or 2 of drug treatment, making sure the drug's hitting its target. So it sort of informs what you hope for later clinically. And those are objective as opposed to subjective outcomes. And so we've already done a lot of the sort of groundwork to do a trial in juvenile myositis, and we're in the midst of discussing that and how to kick that off with CureJM. Next slide. Just some quick disclosures. I'm split time between State University of New York, Binghamton, a new pharmacy school, help run that, but I'm also Children's National Medical Center in Washington, D.C. We set up a lot of infrastructure that, like Jim was talking about, making sure you have the infrastructure in academic centers and a drug development pipeline. So over 30 years, set up mouse clinical trial facilities, so you can see if a drug fixes a mouse first, and your board member, Kanaboy Nagaraju, was critical for that. And then a clinical trial network at, in about a dozen countries that did a lot of natural history studies, and also drug development programs. And those ended up spinning off companies. So Jim's mentioned Reveragen Biopharma, which develops vamorolone. Trins LLC is a clinical trial network management company in pediatric neuromuscular space. And Agata Biosciences with Raju on your board also helps run to help companies do mouse clinical trials, and also help human clinical trials with like muscle biopsies and biomarker studies. Next slide. So I looked up a recent review of treatments of myositis, 2018. And here are your first line, second line, third line therapies, mild to moderate disease, severe disease. But if you just click the slides once, you'll see that glucocorticoids are all over the place. So they're glucocorticoids, prednisone, dexamethasone, all these different glucocorticoids are really still part of generally, it's my understanding, I'm not an expert in JM myself, but standard of care. Next slide. So why do corticosteroids work so well? They're generally reviewed as rheumatologists and neurologists as very strong drugs, almost a sledgehammer to the patient. What they do is bind to a drug target called the glucocorticoid receptor, which is in all our cells, and that drug and receptor combination binds to and activates a ton of genes in your genome. So we have like 30,000 genes in your DNA, all doing different things in different cells at different times. Well, this drug receptor binds to and activates a big percentage of your genome and ramps them up. Now, in that, it ends up suppressing innate immunity danger signals, and a key term there is called NF-kappa B. It's sort of a key hinge point in when a cell says it's upset and it's calling in the inflammatory system to help it understand why it's upset, but that inflammatory system can overreact. And that's really the nature of a lot of so-called inflammatory disease. And so they're really sort of still magic. I mean, they were first tried on patients with arthritis in the late 1940s, and they're really viewed as magic anti-inflammatories. But as we all know, there's a dark side to this magic. Next slide. So there's lots of adverse effects, and particularly with chronic dosing, you have psychiatric, sleep, mood, psychosis, skin, soft tissue, neurologic. They actually cause muscle wasting, so there's a critical care myopathy. So glucocorticoids seem to cause muscle weakness, and yet we're using them to treat muscle weakness, just somewhat counterintuitive. So you have this myopathy, osteoporosis, endocrine, immunologic, immune suppression, cataracts. And then in children, there's additional problems even above those of adults, stunting of growth, mood disturbances, and delay of puberty. Next slide. So as I mentioned, it was 1950s Nobel Prize, and it was only for about a paper with 10 arthritis patients, but they got so much better overnight that it was the fastest Nobel Prize ever awarded by the Nobel Committee's own admission. And in that speech introducing this great breakthrough in corticosteroids, they said, these are wonderful, they're magic, but look at all these side effects. Even those first 10 patients, you have to do something about those side effects. So there's really two questions that the vamorolone program sort of addressed. Can the benefit of corticosteroids be separated from the side effects? And then this other question, which I've always been fascinated with, corticosteroids are the same as all of us have coursing through our bloodstream before we wake up. There are diurnal hormone, so cortisol. So pretty much the same drug, it's just our endogenous drug instead of a pharmacological drug, shoots up at 4 a.m. in your bloodstream in all of us and wakes us up. It's also the stress hormone. So when we get stressed by something, cortisol shoots up. So corticosteroid drugs seem to be some harnessing of the body's own adaptive mechanisms of both waking up and dealing with stress. And it seems that inflammatory responses are really tied into that. But it's been a big question since the 1950s, how this all works. And I think one of the problems of figuring out how it works is if a drug's binding 10% of the genes in your genome and turning them on, there's so much going on, it's really hard to peel away the layers of the onion. It's just, you have a ton of onions with lots of layers, how do you figure out what's causing the what? Next slide. So one key thing, this is sort of your take-home message slide, we're gonna have a test later, is that there's two mechanisms of action that have become clear over about the last decade on how steroids work. So when I talk about binding genes and turning on your genome, that's called transactivation, and that's off to the left of the slide. So there you see the receptor in the drug is that blue curly thing actually binding to DNA. You see the double helix there. It's binding to a certain sequence. You see the sequence down there. And in that is turning on whatever genes are around it in that DNA. On the other hand, the anti-inflammatory effect, the efficacy of the drug seems to be something different, a different mechanism. That's called transrepression. It's shown on the right hand of the slide. If you notice the DNA sequence is different, it's still binding DNA, and it's still the receptor and drug binding DNA, but it's a whole different code. And that code is much more limited. It's limited to really pro-inflammatory genes. And whereas transactivation is turning on genes, transrepression is turning off pro-inflammatory genes. So it's stopping the inflammatory process through an inhibitory mechanism. Well, a key thing is, if you just click the slide, is that the things, it's become increasingly clear that transactivation, which is what most people learn about all steroids and hormones, seems to be mostly side effects, whereas the transrepression seems to be mostly efficacy. One more click. And a key thing that I'll cover in the next couple slides and how vamorolone works is what I just boxed down there. There's accessory proteins, additional proteins, a whole suite of proteins that are brought in to help the receptor bind to DNA and stabilize and activate it. And they're actually necessary. You have to have those accessory proteins, or transactivation or transrepression doesn't happen. But they're different proteins for transactivation and transrepression. So for transactivation, they're called co-activators, and they're necessary, like one is PGC1 alpha. For transrepression, it's a different series of proteins, and they're necessary. So what I'll show you in the next couple slides is that's what we latched on to separate out the transactivation from transrepression, is these co-activators and co-repressors, and we changed how the drug recruits those. Next slide. So here we're actually looking at X-ray crystal structure of the drug, prednisone, or prednisolone is the actual active metabolite of prednisone, on the left-hand side, where it's contacting the receptor, this glucocorticoid receptor. It's binding in its pocket the receptor. And where you see those dotted lines is the contact sites of the actual drug with the receptor. With vamorolone, we've just removed one of those contact sites where that red arrow is. It's very closely related, but by removing that one contact site, we twist the drug a bit in the receptor. And a recent paper in PNAS just this last month really proves of how prednisone, deflazacort, and all the corticosteroids are different from vamorolone, because all the other steroids keep that red arrow, but vamorolone is the only one that removes it. And now we're going to look at the downstream consequences of that, both biochemically and then clinically, in terms of efficacy and side effects. Next slide. So this is now a diagram, sort of a 3D view of the receptor, all those spirals. And you can see the little green drug with the yellow arrow nestled inside the receptor. And where it's bright red is the differences between all your corticosteroids and vamorolone. So what vamorolone does by twisting the receptors, push those red curlicues out. And what that does is change the co-activator and co-repressor binding. So co-activators, which are more side effects, we're actually causing less binding of those. Co-repressors, which is your anti-inflammatory activity, we're causing more binding of those. And so that's just data off to the right. And again, that was just published this last month. So we see how we're separating out what's called a dissociative steroid, trying to decrease the side effects while keeping or increasing the anti-inflammatory activity. Next slide. So really that was the aha moment some 10 years ago when we made these vamorolone and related drugs, that on the left was comparison to prednisone, we were seeing that anti-inflammatory activity. That's the graph going down on the left. Whereas on the right is your side effects. And you see the black line, prednisone is causing this transactivation, the side effects. But you can see vamorolone doesn't do that. Down below, it's just sort of flat. It's not causing the transactivation. So this seemed to be the long sought dissociative steroid. Next slide. So we went first to Duchenne muscular dystrophy. I should mention the whole program for vamorolone, about $70 or $80 million to date to develop this over the last 10 years, has been done in collaboration with foundations and governments. So we've used a different business model than most other drugs. It's called venture philanthropy. I'll come back to that briefly in the very end. But we kept this within the academic space, and we really wanted the academic community to develop this drug. And here was a first trial of 48 patients with Duchenne muscular dystrophy. And what you see is as we increase the dose of vamorolone, the kids get better. They get stronger, they do faster, so their muscle improves. In this young age range, was about 4 to 7 years of age, steroid naive before they entered the trial. The kids are sort of stable. They really decline a couple of years later when they get to 10 or so, 9 or 10. But what we're seeing is a frank improvement of their symptoms. So not a stabilization of disease, but an improvement. This is time to stand velocity. The next slide shows time to run walk, 10 meters. Again, this is as we're going, the graphs are going up, we're going to higher and higher doses of vamorolone, and you see more and more improvement. Next slide. Just one other is a 6-minute walk test. Again, the lower lines of the lowest dose of vamorolone, as we can increase the dose, the kids seem to do better and better. Next slide. So recently, we've seen a lot of satisfaction of families and kids and the physicians with vamorolone. So we do a 6-month clinical trial and then say, well, now you can transition back to corticosteroids, or we give you the option if you'd like to keep on being treated through long-term extension studies and then compassionate use and expanded access with vamorolone. And almost all of them have chosen vamorolone. And so here is a 1.5 years of treatment data in 40 kids, 45 kids that kept on vamorolone that was just recently published. So next slide. So what we see is those kids keep on improving over that 18 months. So most of these are highly statistical significant: time to stand, run to walk, climb to 4 stairs, 6-minute walk, North Star ambulatory assessment. So there seems to be these continued improvements. Now, next slide. These are not blinded studies. These are open label, so you have to use external comparators. You have to be careful of placebo effect. So what we used was a natural history study carried out by the same academic network that did the trials. It's called Synergy, Cooperative International Neuromuscular Research Group. And so we looked at both steroid-treated kids and then steroid-naive kids in that trial. This is sort of a complicated slide, but if you look off to the left, the 4 first groups are vamorolone treated. The left one is really the lowest dose, and they really didn't get much high dose vamorolone. The next 3 groups got a lot, mostly 1.5 years of high dose vamorolone. And then the orange is steroid naive kids. And so the dotted line is baseline as they came in for these measures. You can see the orange kids are pretty much stable. You see that the vamorolone treated kids at the higher doses are doing better compared to when they came in. And then we compare to steroid treated as well off to the right. Now we didn't have pre-post steroid in this natural history study, so we're only looking at after 2 or 3 years of steroid treatment. And what you see is generally the vamorolone kids are doing similarly to the steroid treated kids. We put both the baseline coming in and then after treatment. So the black line is baseline. And you can see the, Duchenne is a bit variable like myositis. So you can see some kids, some groups came in stronger than others. And that's a problem with these pediatric neuromusculars. There's quite a bit of variability. But overall, it seems to work similarly to glucocorticoids. Next slide. So these again are open label studies, not double blind placebo controlled. We have a broad dose ranging, so 26-fold range of drug. Efficacy outcomes all showed dose responsive over 6 months with continued improvement over 1.5 years. Seems efficacy similar to corticosteroids, but we're doing the current head-to-head studies now. But the key thing that we started this is what are the safety and side effects? Next slide. So one we can look at over 1.5 years is a classic problem with corticosteroid treatment of kids chronically, which is stunting of growth. So recently a drug called Emflaza, which is deflazacort, a version of prednisone, was approved for Duchenne muscular dystrophy by FDA. The clinical trial was done some 15, 20 years ago that was used for approval, but this is the data from that clinical trial that was used for FDA approval. And what you see is basically every kid on Emflaza or deflazacort stops growing, which slows their growth velocities relative to population norms. Whereas vamorolone, it actually goes the other way. So you see everybody actually increases their growth. And if you do a p-value, and again, this is not a direct head-to-head comparison, but you can look at these growth velocities normalized to age and the whole population. So we think this is pretty robust. So it does seem that vamorolone does not do the stunting of growth you see with corticosteroids. Next slide. Then we also looked at physician-reported safety concerns. So you've heard of cushingoid, I'm sure you're familiar with that, the moon facies. And you see in this clinical trial of deflazacort, 60% of kids were reported as showing cushingoid, were only 2% of vamorolone. Excessive hair growth, again, high number in deflazacort, not in vamorolone. And we're not seeing the behavior change. It's always hard to measure behavior change quantitatively in kids, particularly little kids. Certainly there's evidence in this and also anecdotally in the clinical trials. There seems to be less behavior change issues with vamorolone. Again, these are physician reported, so it's really, we're counting on the physician, so this is not quite as strong as the height data, but it seems suggestive. Next slide. So just a summary at this point, vamorolone seems to have similar efficacy to corticosteroids. Caveat is, seems to show less safety concerns in corticosteroids, no stunting of growth, normal biomarkers, anecdotal behavior and sleep improvement. We currently are completely enrolled just over the last month, 121 kids, 33 sites in 11 countries of a registration trial. So that's a double-blind, placebo-controlled, prednisone-controlled that should go to both FDA and EMA drug approval. That readout's in March 2021, so in about 6 months. And we're looking at approval in late 2021 or early 2022, of course, if we get results worthy of approval. And the structure-activity relationships of the drug receptor are consistent with the clinical findings, with loss of transactivation and safety concerns, but no loss of transrepression in the anti-inflammatory activity. Next slide. So I was posed a couple of questions. I answered a bunch of them already, but it's some that I didn't yet answer from CureJM. How and why it works in Duchenne would appear to apply to juvenile myositis and other autoimmune disease. And certainly, I think we agree, yes. There's promising preclinical studies in mouse models of asthma, multiple sclerosis, inflammatory bowel disease, gliomas, and arthritis. And in each of these instances, vamorolone seems to work as well, if not better, than corticosteroids, and again, without the side effects, at least in mice. So assuming approval in Duchenne from the FDA, what is the anticipated time period for approval? I just briefly mentioned that, probably around Q1 2022. Next slide. As I mentioned, this was a different business model. It's really run by academic medicine. We've partnered with 14 nonprofit foundations. We often do what's called venture philanthropy, where with a grant from the foundation, we have a contract that gives 400% return on investment based on later drug sales. Of course, that assumes that the drug's going to get approved and sold, but that's sort of shared risk, shared investment sort of model. Lots of NIH grants. The European Commission gave us a 7 million grant, 400 applicants for 10 grants, and work with Newcastle University to get one of those. So altogether, we've done about 70 million of non-dilutive capital. And the non-dilutive is important because it's really the academics and the foundations that are calling the shots, not so much venture capitalists or people just worried about investments. So with that, we've made a lot of innovative trial designs, rapid implementation, biomarker studies. I've mentioned we've done a lot of biomarker work already with JM in multiple contexts of use. And with large academic clinical trial networks, which is in fact what we're working with CureJM and looking at designing a JM trial going forward. Next slide. So just acknowledge the study chairs, Paula Clemens of Pittsburgh and Michaela Guglieri in Newcastle, recruitment sites, trial management, the development team. We're a very small company. We have 4 full-time and 5 part-time employees, and financial support, as I mentioned, from US and European governments and lots of nonprofit foundations. Next slide. This is the last slide just showing the different foundations and governments, including the Department of Defense that we've worked with over the years. So happy to open this up for discussion and answer any questions.
Thank you, Eric.
I think we might be on mute, so it'll take people a minute to come off them as well.
I just have a question. Is there any way for any of our children to become part of the clinical trials? We personally are in like a critical phase. Our CK's at 30,000 and we're desperate.
So what we're trying to work with CureJM is to start a clinical trial in JM. So the first step of that is what's called a pre-IND, where you go to the FDA and outline your clinical trial you're proposing, and they hopefully give you the go-ahead to continue. So that's what we're currently discussing, and CureJM is considering a grant to Duke University to sort of organize that. I should mention that we recently had COVID's created all sorts of issues with all sorts of companies and everybody, as you know. So we had to do some fancy footwork ourselves, and with that, we have a partner called Santhera in Switzerland. And so now we have to, that just happened over the last month. So I'm lining up calls with CureJM and this new partner, Santhera, to make sure they're on board with the CureJM plans, and so we can get that moving. But yeah, as far as, some drugs as they get approved, you can prescribe off-label. We're not approved, so that's not an option at this point. There are things of compassionate use or expanded access that sometimes it's possible to get access to a drug before approval, but we're such a small company with limited resources that our current programs are only to those Duchenne patients that have already participated in trials and want to continue treatment, and their siblings.
Right.
We just don't have the bandwidth to open it up. But the goal is to get this CureJM trial going as soon as possible.
Okay, and then thank you so much. I appreciate all of the work. And then Jim, would you facilitate that information to the parents once there is an opportunity for our kids to be part of a clinical trial?
Yeah,
If
go
I
ahead,
could
Andrew.
just jump in for so I think, as Eric was stating, what we've actually done in the last few months is we've established a key group. As Jim was mentioning, one of our key centers for excellence is based at Duke University. We have Professor Anne Reed, Dr. Jeff DeVersten, and Dr. Kaveh Ardalan based there. But critically, Duke have also got something called the Duke Clinical Research Institute, who are specialists and world leaders in setting up clinical trials. So our aim with the Duke group and with Reveragen, as Eric said, is within the next 3 months, we certainly plan on getting a meeting together with the FDA.
The FDA.
Just primarily so that we can drive the next part of the program forwards. And it's really the FDA that are, as Eric was indicating, that are key to helping us generate that next stage of planning the clinical trial and taking it through. But the key thing from a JM Foundation is, is obviously speed. We are very aware of that, and that's why we feel very confident with a combination of Eric and DCRI and Duke. We've got all the pieces of the jigsaw in place now.
Oh, wonderful. Thank you so much. I really appreciate it.
Yeah, and Katie, we'll be sure to get your information to
Yes.
both Dr. Hoffman and Jim and Andrew so they can follow up with you.
Oh, that's wonderful. Thanks.
Thanks, Katie.
We have another question, Dr. Hoffman, coming in on chat. Is there anything you can do to expand on the 1% personality change that you saw with vamorolone, and what would that mean for some of our kids?
Yeah, I think, as I mentioned earlier, that personality change or behavior change are slippery things to measure, particularly in 4 to 7-year-olds. Keep in mind that Duchenne kids also are a bit off the standard sort of curve for like ADD and other behavior conditions. So it's hard to say. I mean, what we have, first of all, it's hard to measure in a compelling way. But there's certainly anecdotal stories. So I'll give you one example. In our 004 study, the first 6 months which is currently the registration study, what's already enrolled with 121 kids. The first 6 months, kids are randomized 25% to placebo, 25% each to 2 doses of vamorolone, and then 25% to prednisone. So they don't know what they're on, and they go to 6 months, and then everybody crosses over to vamorolone. So everybody that was previously on placebo or prednisone now goes on to vamorolone. Well, there's been cases of kids in that first period who had really bad behavior change. I mean, really got kicked out of nursery school because with the drug, their behavior was terrible. And they were even considering withdrawing from the trial. But they made it to the 6-month period, crossed over to vamorolone, and the behavior normalized, and they went back to nursery school. So again, we don't really know what that kid was on in the first 6 months, but given that we know prednisone causes behavior changes and the fact that that seemed to disappear when they crossed over to vamorolone seems promising. But you know, the blinded study will really help answer that when we look at unblind all that, which will happen in March. The question I see there is, do you anticipate the upcoming JM trial to be a placebo-controlled trial with a crossover as well? I think we have a synopsis, which is sort of a general outline, and we're still finalizing that. But with JM, I think what we're looking at is treating flares. So, you know, a child has a flare, you treat with vamorolone, really probably only a 4-week treatment period, and see if we can treat the flare. Really, a pilot trial like that is not to prove efficacy to a point where you can get drug approval. It's to sort of de-risk the program, to sort of provide, you know, the physicians, the foundation, and everyone, the parents, that there seems to be efficacy there. It seems to be promising. So now let's invest in a full-fledged blinded trial. Now, with a disease like JM, you know, in children, it's probably difficult, if not impossible, to justify a full placebo. You know, you do need to treat flares. So it probably will be some sort of active comparator, but we really haven't gotten there yet. We're really just planning the 4-week pilot trial to look for some suggestion of efficacy.
Do we have any other questions for Dr. Hoffman?
I hate to take up all the space. I have 2
Oh.
questions. Are you as immune suppressed on this as you would be on prednisolone, and would you expect the same amount of infections?
That's hard to say. I mean, we have mouse data which suggests, but does not prove, that we don't show the same immune suppression. So we're gathering data there, but again, it's relatively early days, and you sort of need a long time of treatment in a lot of kids to really look at infection rates. But at least there's some preclinical data suggesting we don't. That we're not immune suppressive, we're anti-inflammatory.
Oh, great. And then so obviously we use steroids now in between trying to figure out the next immune suppressing drug, from cyclosporin or methotrexate or whatever that may be. If this works without side effects, what would stop us from taking all of those away and just using this?
Mm-hmm.
Well, that's why you have to do clinical trials, and it's always this balance, as you know more than anybody, of, you know, trying to get the trials that actually provide evidence-based medicine, which also makes it easier for insurance to cover, as opposed to just trying things off-label and hoping for the best. So, I mean, that's all what we're all going to have to reach a consensus on going forward.
So there's potential that this could be a lifelong drug, or too soon to tell?
Well, certainly Duchenne kids, we have kids on it for more than 4 years now. So, and it's every day. They get it every day, but that's how they treat corticosteroids. So, you know, Duchenne kids don't have flares. They just have a chronic disease, and they get treated daily with corticosteroids, relatively high dose. I mean, 0.7 mg per kg per day, once daily, oral. So that we'd replace corticosteroids in that context, and they'd be lifelong. I think as you use you know, our best guess, and again, all this needs clinical studies and lots of consensus building and feedback from parents and physicians and the patients, and see how they do. But, you know, you're really ramping up steroids to treat flares. Would guess that vamorolone might be used the same way. But that needs a lot of work and discussion.
Thank you.
And one question you might have seen on Eric, from the president of our Pacific Northwest chapter. Her daughter is actually 18. So is there, what are your thoughts on children who are actually adults and when they would be able to take vamorolone?
Well, almost all drugs are first developed in adults and then later brought to children. We've certainly inverted the paradigm here in our first patients or young children. That's very unusual. In fact, we got a $2 million grant from NIH to do a pediatric ulcerative colitis pilot trial, but FDA came back and said, no, you have to do adults first.
Mm-hmm.
We have all this pediatric data. And there is some concern that with myositis, will FDA do the same thing? We hope that it's closer to muscular dystrophy, and the adult and the child distinctions are important enough, but it is still a risk. And so we still need that pre-IND to go to the FDA and say, are you on the same page as us, to make sure we can go straight to children. But the point being is that we've done volunteer trials. Your phase 1 trials are on adults. I should mention we've only done males to date. So that is a deficiency of our program, is we haven't tested any females, even in volunteers, and we're trying to fill that gap. And that's also something that's been discussed with CureJM and the physicians. Will FDA allow us to go to children that are females if we don't have all the adult volunteer data first?
And then the only other question that I had, and Jim, you may have others coming in by text, was a parent who's pointing out the fact that she doesn't believe any of the drugs her child are on, and Jim would be able to corroborate this, are FDA approved for JDM anyway. So is that really something that a parent needs to be concerned about? Because aren't the treatments we're taking now off-label anyway? That might be a question for you, Jim.
Well, go ahead, Dr. Hoffman, but the answer is yes. Every drug that is taken by prescribed to a JM child is prescribed off-label. Now, some of those drugs that are prescribed off-label do have academic studies or trials behind them, as Eric was saying, but many do not, and so. And have been shown to be somewhat helpful, really through more of a trial and error process. So, yes, without question, a part of our strategy here is we know the road to essentially being an approved indication is a long and arduous one. And our goal is to get this drug available to kids at the earliest possible date, which essentially is an off-label strategy.
Mm-hmm.
Eric, you want to add anything, or Andrew?
Well, only from the pharma, as a drug developer perspective, I'm not allowed to say anything about off-label.
Yes.
And so
there you go.
This has certainly all been discussed. Andrew?
No, Jim's exactly right. Everything that gets prescribed at the moment, they're part of that, as everybody is aware, of what we call consensus treatment protocols. So, their basis comes from all the pediatric rheumatologists and all the experience they have with a variety of drugs, with kids that present in different ways, and they have, a suite of drugs that will work better for kids with more skin component, a suite of drugs that will work better when you've got severe muscle weakness. And they've been developed by, over years. But as Jim said, these are not registered for JDM as such. So, the pathway for vamorolone, and certainly what we're working with Eric with, is to get it into a pediatric trial. I think, as Eric mentioned, that's not straightforward. The FDA is a very conservative organisation, and they always like to see adult data before they see pediatric trials. But as Eric mentioned, we've got what we think is a unique strategy and a unique opportunity and a unique patient set that we can really leverage off and convince the FDA that this is something that is going to be of significant value to our patients. So they really should let us start this safety study. So the first study is only going to be, as Eric said, a relatively small study. It's going to be primarily safety outcome based. But the hope is that, as Eric mentioned, he's got so many years of data with this drug that, he's convinced it's relatively safe. We're convinced it's relatively safe to start this first safety trial and go on from there.
Great.
Can I jump in real quick? I no longer have a child that's being treated, but I'm just trying to read between the lines and what I've heard today, and maybe others might be thinking the same thing that are on the call. So I'm just going to ask a question, see if it resonates with anybody. So based on what I've just heard, this drug that we've gone through and looked at the data looks to be something that could be positive for kids with JM. If somebody that's on the call goes and talks to their rheumatoid arthritis doctor and asks specifically for this drug, even though it's not in any specific trials right now for this disease, would that doctor be able to prescribe it off-label to them?
Not until it's approved. It has to be approved it would have to be approved for something first. And our goal is to get it approved for Duchenne next year. So once it was approved for Duchenne, then what you said is right, but that's not quite where we are yet.
Okay.
So, Damon, just to fill out on that, it's, what we've got as a strategy from a foundation perspective is, as Eric's approval for Duchenne comes out, then, our intention is to be starting the JM trial as close to that as we possibly can. And I think, everybody's going to know, all the doctors that are going to be running the trial for us and recruiting patients into this trial. So the aim is that all the key docs that we've got on our medical advisory board can really start to amass some data. And, they're the ones that are going to be making the decision based on A, the approval in Duchenne's, but then B, what evidence they see in this first safety study as to how confident are they that it's showing efficacy and it's got an appropriate safety study. So, we're trying to get this thing rolling along as fast as we can. Certainly the Duke group are very excited about taking it forwards. The foundation, we are, extremely excited about working with Eric to get it going forwards as fast as we can.
Okay, thanks.
Great. Well, Eric, thank you very much for that way extraordinary, and I think you can all see why why we are so excited about the potential for this drug for our JM kids. As I mentioned at the outset, there are a couple of other drugs that we're also excited about pushing toward clinical trials. We'll be talking about those in future meetings, but I think right now the one that is generating, I'll speak for myself on this one, the most enthusiasm because of its extraordinary potential yet to be tested in JM is vamorolone. So, Eric, thank you so much. Thanks for your collaboration with Cure JM and for for everything that you do, and I know you want to do for our kids. We're most appreciative.
Thanks. It was a pleasure speaking with you. You have a nice evening.
All right. Great. Thanks.
Thank you.
I'm going to now introduce someone I mentioned at the beginning of the call, Denise Cook, who is the chair of our National Leadership Council. I first got to know Denise when shortly after I first came to Cure JM, when she helped us organize and stepped up to be the president of our Chicago chapter, one of our larger and very successful chapters. Early on with a walk, in part because of their large patient base and longtime partnership with Lurie Children's in Chicago, and her enthusiastic, all-in leadership for Cure JM. And I really have to mention her husband Roger as well, who has been at all of our conferences by her side. really reaching out to families and to new families, welcoming them into the Cure JM world. So Denise, thank you. I know you've got a few messages and information that you want to share with our NLC tonight. So over to you.
Thanks, Jim. Hi, everybody. I want to thank you all for joining us and also for your tremendous support of Cure JM. I think you all are a lot like me. When my daughter fell ill and we entered this journey, there's nothing I wanted more than for her to be healthy again. For her, I mean, that's all we want. So that is why we have this enthusiasm. This is why when we set our minds to it, we really make great things happen. I do want to thank Kevin Coffey for his great leadership. He has turned the NLC chair position over to me, and I thank him for that. And I will try to be as good at it as he was. I want to give you all an update on the recent success of Walk Strong Across America and how your efforts are making research like Dr. Hoffman's possible. The Walk Strong Across America was our response to the COVID-19 and the fact that we couldn't have our in-person walks. As a result, our families and leaders, many of which are on this call tonight with us, banded together to raise $675,000, which is truly incredible. All 50 states were involved in some way, and we will be working over the next year to increase involvement in each of the states. And so many of you that have been invited to the call tonight were just a big part of the success. I want to especially thank our state and regional leaders and all the chapter and all the walk leaders. They successfully engaged 350 families to participate in the walk, which is truly exceptional. In total, $675,000 was raised, which proves that our families can indeed do anything that they set their minds to. And I would also like to thank some of our newer members of the council. These are people who've demonstrated exceptional leadership over the past few months. 3 of these families had tremendous success in taking on an interest of their own and then creating socially distant fundraisers. A big thank you goes out to Veronica Montero and Todd Scheid. Their daughter Clara and Todd rode their bikes from San Francisco to LA and raised over $20,000. Jeff Bornemus, a friend of Zach and Sandy Harrison's in Columbus, Ohio, held his 2nd annual Swing for a Cure Columbus, a golf outing in August, and raised $15,000. And Laura Lee McIntosh held a purse auction at her local Moose Lodge and raised over $20,000 in honor of her granddaughter, Charlie. I was greatly inspired by all of these fundraisers. I mean, it has amazed me how we took from trying to schedule, not trying to schedule, but actually getting all the groundwork done for the Chicago walk that was supposed to happen in May, and boom, COVID happened. And instantly, all these walks across the country, all these families across the country, we switched gears and we made something tremendous happen. So with that, I would like to hand this back to Jim so he can update us on the 2021 budget and programs. Thank you.
Thank you, Denise. Yeah, briefly, because I know the hour is getting late. Let me just say that we are just a few days away from closing our fiscal year, our fiscal 2020 fiscal year ends on September 30th, and I'm very happy to report that that our budget will come in this year balanced, that we raised what we had hoped we would raise, which is a little bit over $2 million. And that we've spent that money also pretty much as we anticipated to spend that money in support of grants, in support of one small clinical trial, and in support of our 4 centers and our chapters and families around the country. We remain an organization that spends about 80% of our revenue on program, the majority of that being in the research area. And that will hold true as we move into fiscal 21 as well, where we're looking at a similar budget to this year, slightly higher expenditures and slightly higher revenues as we continue to grow. I think what's particularly heartening is that for those of you who read about the impacts and know about the impacts of COVID-19, particularly on nonprofits, let alone the economy in general, we were able to really hold our own and meet our budget in an otherwise very challenging year because of all of the work that you and dozens, if not hundreds, of others volunteer leaders did across the country in last year's holiday challenge, and in all of the creative things that you did in helping Walk Strong Across America be such a success. So we're very confident as we go into 2020 that we will continue to be that sort of little engine that could. At $2 million, we're a very small nonprofit, but I believe we have a very outsized outcome for what we do because of the generosity of our families, the generosity of the friends of our families, and the fact that our grassroots, really do. When they hear the call to action and know what we need to accomplish as a small organization to help our kids get better, respond year in and year out, and because of that, we've really been able to thrive. So even as we look at next year's budget of $2 million, that will not be adequate to cover some of the larger plans that we need to be looking at in not only fiscal 21, but in fiscal 22. And specifically here, I'm talking about, for example, and just one example, the cost of this vamorolone trial. We anticipate that from the very first phase, which will cost in the neighborhood of $100,000 through the enrollment of some 20 or 24 patients and the conduct of that trial across what will probably be a couple of academic centers, that the cost of that trial will be in the neighborhood of $1 million. Andrew has put together a very detailed budget that looks at what those costs are, and that $1 million is fundamentally over and above the investments that we are already making in research. So we've still got some work to do on the fundraising front in fiscal 21, in order to generate enough revenue over the next couple of years to fully fund that trial. I'm very confident that we can do that. And the other thing I'm really happy about is that we have had to be an organization, because of the rareness of this disease and the size of the organization, that has really needed to leverage our funding. We've done that with virtually every program we've done, major program that we've done, whether it's our genetics program with Children's Hospital of Philadelphia, our drug discovery program that is really where a number of these JAK inhibitors have come from with NIH, and my thanks again to the Coffee family for funding that project, as well as the upcoming vamorolone trial. You heard Dr. Hoffman mention that they have invested over the past 10 years, $70 million in the development of this drug, towards which we've made, fairly modest contributions. And if you think of, a contribution of $1 million, a lot of money for us for a clinical trial for vamorolone, relative to the $70 million that's already been spent in the drug's development, safety testing, and clinical trials, you can see that we will be getting a lot for very little. That's the very concept of leveraging our money in collaboration with organizations or biopharma like Reveragen, to end up with a product that is, potentially an enormous game changer for, for our kids at a relatively modest investment. I don't mean to say $1 million isn't a lot of money. It's a lot of money to us, but it's an extraordinary return should this drug turn out to be successful in JM, and we have every reason at this point to believe, as you heard from Dr. Hoffman, that it will be. So in the immediate future, we've got our holiday challenge coming up. Shannon Malloy, as you know, has been the holiday challenge maven. She has run everything. She has really worked, her management magic with all of you and with our families across the country to develop teams, to help you with your fundraising pages, with your outreach. I think we have, Shannon, about 140 families that are registered and signed up already for the holiday challenge. For those of you who have been a part of this organization for a number of years, you know and are very much aware that when there was a prize that was associated with the holiday challenge, for the most part, in many of those years, we would win, first place, couple of years, second place, but we were, a substantial beneficiary of those prizes over the years, which have unfortunately been discontinued, but which we've also replaced over the past couple of years with a similar prize from a couple of our generous families. The last couple of years, that has been the Leitz family from Indiana. For the upcoming campaign, it will be the Coffee family of New York. So again, Kevin and Marge, thank you very much for your extraordinary generosity. These incentives that we're able to utilize in the holiday challenge, I think especially with a number of our first-time families who are coming into the organization and will help us get this extra $1 million we need to raise. I just can't say, can't be thankful enough for what that means towards our success. So with that, I just want to leave you with the thought of, if as you're ready to ramp up your own pages for the holiday challenge, that for us really culminates on Giving Tuesday, which is December 3rd this year. Is that right? December 1st this year. Thank you, Shannon. That will be, as it is every year, our big day, and we're looking forward to some extraordinary success. The last thing I want to say is we have coming up on October 17th a new drugs in JM. It's a symposia. It's a medical symposia that Dr. Heaton has put together for us. We have some extraordinary presenters, including Dr. Hoffman, who you just heard, but also a number of clinicians from Children's Hospital of Philadelphia, from the Duke group that Andrew was talking about, from NIH with an important Janus kinase, JAK study in baricitinib, another drug some of you have heard about. And I think what's going to come out of this medical symposium is some extraordinary momentum in drug development. This sort of goes all the way back to what I was talking about at the beginning of tonight, in terms of drug development being, essentially our #1 priority. Our kids need these drugs because they are the best hope they have for better treatments, faster treatments, and treatments with fewer side effects. So we're really wanting to remain focused on this. This medical symposium, essentially, which lasts, I think, 4 hours, Andrew, is that right? I think it runs on October 17th. You will all be receiving an invitation to attend and listen in to to the symposium. So mark your calendars for the 17th. I think it's 10 a.m. to 2 p.m. Eastern time. 11. Thank you. Eastern time. Mark your calendars. An invitation with a registration Zoom login will be coming your way. But also, attendance to this is a medical conference, so it is exclusive to members of the National Leadership Council. So please don't share that widely. We really don't have the capacity for hundreds of people to attend, but certainly for all of you and all the other members of the National Leadership Council, we hope to see you there. Let me stop there. We're 7 minutes over, but if anyone has any questions for Shannon or Andrew or me, we're happy to take 3 or 5 more minutes to answer them if anyone cares to stay on.
It's Luke here in Boston. I had a super quick question, and thank you very much for this. With vamorolone, are we seeing any adverse side effects that you wouldn't see in prednisone? Is there anything that this drug brings on that the other current treatments would not have as a side effect?
Great question. I don't think so. Andrew, you want to tackle that?
No, Luke. It's all the side effects are much milder, as Eric was pointing out, and some of them compared to the standard steroid treatments are just non-existent, as he was sort of alluding to in his talk, just because of what we're doing from a signal transduction perspective. We're just not turning on those adverse genes that steroids normally turn on. I mean, the caveat here is that, as Eric pointed out, because Duchenne's is a male-only childhood disease, it hasn't been tested specifically in young girls yet, but we've got an awful lot of safety data. We've done an awful lot of all the FDA-required pre-IND tox data in both male and female dogs. So we are very confident that it is going to be safe in young girls as well. And, that's the prime reason for us wanting to, before we spend and start doing that big fundraising, as Jim was mentioning, to actually fund the trial, it's, we really want to have a very clear clinical, not just a clinical synopsis, but a clinical protocol. And we want to be able to tell you that, this person is running the clinical trial. It will start on this day. This is the number of patients we require. So we're going to get the FDA involved early in the piece, get their buy-in, get their advice as to how we should run that first trial in JM patients using both young boys and girls to ensure that we've got something that, is safe, but importantly, we get this really critical drug available for our patients as soon as we possibly can.
Great.
Well, thank you very much, everyone. Could I ask a follow-up question? I don't know if someone, and thank you for that. Would this replace just prednisone, or would it also replace methotrexate, IVIG? Would it be like the drug then that basically just, no? Okay.
Probably not. It's mode of action, as Eric was really implying. Steroids are very good when your child's suffering that flare and you need something to really quieten down that flare very quickly and very effectively. It's going to replace the steroids for those sorts of things. The methotrexates and IVIG, different mechanism of action, and it's not going to replace those. As such, it's they're more sort of long-term drugs that are utilised, slightly different settings, often to what's happening when our kids are flaring.
Thank you very much.
Do we have another question? Okay.
If I could jump in real quick with a 30-second thank you to Sue Carpenter. I want to make sure you guys are all aware of an excellent resource that Sue has, in addition to taking care of the family and teaching kids on Zoom and training a new puppy. Sue has taken every night of the last several months and worked really hard to put together what I think is going to be an excellent resource for you all and for our families, which is a list of doctors that we know have some level of expertise in treating juvenile myositis. You know, it's not a list of recommended doctors. It's not a list of necessarily, you know, every doctor that treats JM, but it's a list that you can provide to families when they ask you, and can provide to members of your chapters. So that list is at curejm.org/doctors. And reach out to Sue or I if you have any questions or concerns or additions or deletions, and Sue can make those changes right on the website. So we just want to recognize you, Sue.
Yeah,
We talk a lot on this call
Thank you.
about fundraising, but there's a lot more that happens behind the scenes to support the families and improve the quality of care for the kids. And Sue, you're a big part of that. So thank you.
My pleasure. Thank you.
Thank you. All right. Thanks, everybody.
Just 2
Go
seconds.
ahead, Andrew.
Shannon has probably organised or will be organising. We're going to have another little town hall on the 11th of November, I think, Shannon?
Yes, yes.
On the 11th of November, I'll be getting together Dr. Carvey Ardelin and probably Dr. Jeff DeVergton from Duke to give a lay summary of the medical conference that's happening on October 17th. We'll make sure that we send an invite out to that. But I think importantly, just following on from tonight's meeting, is myself, Carvey and Jeff, and a few other folks at Duke are the key leaders behind Vamorolone. So we'll aim to give you an update then as to how we're progressing with Vamorolone. Everybody's excited about it. We've got some momentum and we want to keep that going. So it's like, for those people that are interested in it, log in on the 11th, keep that date.
Yeah, and I apologize. I just looked at my calendar. It's Sunday night, 8 p.m. Eastern on November 1st.
November 1st. Okay. I'll put that in my calendar. Thanks, Shannon.
All right. Well, once again, good night, everybody. And we'll look forward to hopefully seeing you, some of you at the medical symposium. Thanks,
Okay.
and talk soon.